couple of things. First of all, thank you all for coming this morning. This Saturday mornings in the spring are precious, and probably many of you are aching to get back into your garden. I also want to thank Jill for inviting me to speak here today, and I want to thank Molly Murphy, who's in the crowd here. Molly is our liaison with the company Prostate, which is the manufacturer, the design, the developer and manufacturer of this technology, and it is a very it's a very complex machine. Uses robotics and AI, and the company provides a technician to be there for every case. Molly's worked with me on my first 6, and we had Peter there yesterday for 2 I did yesterday. The company is highly committed to Marin Health and to this procedure, and you coming up to join us this morning and providing me the slide set is greatly appreciated. I should also, thank you all as taxpayers in California, because I went to UCSF, and you subsidized my education, and I've been trying to work it off ever since. So I'll be speaking this morning, as you know, about Aquablation, which is really the newest technology that has come along to treat an incredibly common problem that men develop as we get older, where the prostate gets larger. And my partners and I'm with 4 other urologists, and our practice dates back to the 1950s, and I joined, as Jill said, in the late 90s. We have seen 20 technologies come along, and we have generally stood on the sidelines, and our philosophy always was not the first, but not the last to pick something up. And we have this would be applicable to our use of the robotic surgery Da Vinci for cancer, and we have an incredibly strong robotic surgeon. When this technology came along, we had been on the sidelines watching another, a half a dozen technologies come, but when this arrived, we thought this really looks like the real deal, and it is living up to that promise for us. So I'll go over really the top 3 things here. What is BPH? What are the treatment options that are most commonly used and that seem to have stood the test of time? And where does Aquablation fit in that? I don't have, I have some patients in the audience, some of whom have had the gold standard procedure from the past, and some of whom may be having a procedure in the future, but I won't be introducing patients here today. So what is the prostate? The prostate is a sort of it's a gland, has a kind of a rubbery consistency, and it lives just below the bladder, as you'll see on the diagram, and the urethra flows through it down to the tip of the penis. And patients often wonder, gosh, I've got the urethra, the tube, and now you're going to operate on the prostate. How are you going to get through the urethra to the prostate? So how are you going to operate on this when you've got to get through the tube? Well, the urethra, as it runs through the prostate, it's just the lining. I consider it sort of the wallpaper of the bladder, runs right down through the prostate, and then it lines the urethral tube. And as it runs through the prostate creates like a cleft. It's more like 2 giant pillows of tissue that have grown over time, and the urethra is the wallpaper that coats the inside of them. And when we do a procedure like Aquablation or a resection of the prostate, we're going right through the wallpaper into the tissue, and then in the weeks after the procedure, that wallpaper grows back, and it grows back with a larger cavity here. This has grown, as shown down here, and we do a procedure, and after that wallpaper, just the urethral lining, just regrows in now a much larger chamber than it was before, well treated. This is more anatomy than a medical student needs to know, so I'll spare you that. But the point of this is to get at that while the prostate, for most, from a urinary standpoint, the problem is it's blocking the flow. Well, the prostate's doing a lot of other stuff as well. Why do we have one? Well, the prostate and the seminal vesicles, these organs that sit below the bladder, that is where the fluid of the ejaculate comes from. The ejaculate is 98% fluid from here, and 2% sperm contributed by the testes. This is why after a man has had a vasectomy, there's actually no change in the ejaculate because there's only 2% of the fluid missing. So historically, a challenge of treating prostate conditions is that it helps urination, but it also historically has had a major effect on sexual function, whether that might be ejaculation or in the case of cancer surgery, it can have an effect on erections per se. This is a slide just putting up some numbers about the prevalence of BPH. It is virtually universal that the prostate will grow to one degree or another as men get older. If the prostate at the time of, let's say, a 25-year-old will have a prostate that's the size of a very small walnut, the prostate can grow to be the size of an orange in some individuals, and it's quite variable how quickly it grows. It's hard to predict just looking at a fellow. And it's also hard to predict to some degree based on symptoms. Some guys with relatively small prostates have terrible symptoms. Other patients of mine have huge prostates and only minimal symptoms. But overall, virtually every fellow will notice that his urination changes as he gets older. As we'll talk about, the initial therapy historically has been medication, and there are two main classes of drugs that we use. One set, the alpha blockers, relaxes the prostate, and the other, finasteride being the main one, shrink the prostate. But these medications have side effects. Some patients tolerate them well, some patients tolerate them very poorly, and they're not effective in all patients. So this describes how many men are being treated, and when they talk about pharmaceutical fallout, many patients will come back and say, well, it either didn't work or I didn't tolerate it, and then we have to think about, well, what's the next step? And this is an estimation here of 400,000 surgeries per year in the United States, and there are probably 15 procedures, or maybe 10 to 15 procedures that are being done of various different sorts based on the patient population and the symptoms a fellow is presenting with, and also based on the practice. Some practices get very enthusiastic about one thing or another. My sense is, and I think Molly and her team would attest, Aquablation is very rapidly sort of replacing a lot of those other procedures that have been in the toolbox for years. Yeah.
You ever remove the prostate?
Yes.
Some men have had prostate surgery and had complications and incontinence
Yeah.
but you just remove it too. That's like the worst possible scenario.
Okay, yeah, let me go back. Let me describe that for a second. Let's go back a few if I know it. Yeah. So the question was, hey, this prostate's causing all this trouble. Do you ever just take it out? Okay. The answer to that is yes. But the removal of the prostate entirely would typically be called a radical prostatectomy, and that is indicated for cancer. It's indicated for cancer in a man young enough to benefit from the in-depth or the complicated nature of that operation. And removal of the prostate does not involve just removing the inside like I was talking about earlier, expanding this. It basically involves cutting the prostate away from the bladder and away from the urethra and then reconnecting these. And that is a procedure that is done with the Da Vinci surgical robot. So that's radical prostatectomy, and then everything else that I'm talking about today is not that. And I have had patients who come in and they say, hey, I've got these urinary symptoms. I might someday get prostate cancer. Why don't you just take my whole prostate out? Just cut to the chase and just take because removing the whole prostate involves separating the prostate not only from the urethra here where the sphincter is, that leads to some of the complications that this gentleman was referring to, patients who leak urine. That can happen with that procedure. It also involves taking it away from the nerves, the neurovascular bundles, which provide for erections. And so if you've had a friend who had an operation and he is leaking urine and he is having difficulty with erections that he didn't have before, he almost certainly had a radical prostatectomy for cancer, not any of the procedures that I'm speaking about today, which really have very, very low rates of leakage afterwards, urinary incontinence, and very low rates of erectile dysfunction. Okay, so we're talking about not removing the whole darn thing, which can be done very, very well. And I've already mentioned Dr. James Yu is a sort of a virtuoso at those procedures. So this is a kind of a complicated slide. And when I'm seeing a patient and they're asking me about treatments for different symptoms, I'm trying to break down those symptoms into two categories. The ability to hold urine. If you think about what the bladder does, and the bladder physiology is very, very complicated and with different nerve receptors and different types of muscle and all of that, different types of tissue and muscle and mucosa. But really the bladder is trying to do two things. It's trying to hold urine and it's trying to get urine out. So it has a storage capacity and a storage function and an emptying function. And it turns out that if I meet with a man and he's describing his symptoms, I can sort of put his symptoms into two different categories. Is he having a problem with holding on to urine, feeling tremendous urgency and frequency, sometimes urgent continence, can't hold it? Or is he having a problem of obstruction, of emptying, so a very slow stream, difficulty getting the stream going, an intermittent stream, episodes of urinary retention, that sort of thing. And it's important for me to make a distinction there because the operations that we do, like aquablation, they are really, really, really good at the emptying problems. If a man comes in and he's saying, I can't get the stream started, I can't get the urine out, I'm going frequently because I can't get the urine out, this procedure is especially good at that because it's going to remove the blockage. Most patients with the other type of symptoms, the frequency and the urgency and the urgent continence, most will get better with this procedure on the prostate, but sometimes those symptoms are arising from the bladder itself, what we would call overactive bladder, a condition that both men and women have. The bladder is basically the same with men and women. An overactive bladder describes those symptoms of, I got to rush to the bathroom, or I can't hold it when I need to. Again, men and women both experience this. And when I'm talking to a fellow who comes in and says, hey, I don't have any trouble with my stream, I can pee with a strong stream, but boy, I can't hold it, I begin focusing a little bit more on the bladder and a little bit less on the prostate to see if we can figure out the appropriate treatment, appropriate approach there. I imagine when you go to your doctor, you're often filling out forms. And if you come to our office, you will almost always be asked to fill out something called the IPSS or the AUA symptom score. With those, they're essentially superimposable questionnaires that we give men. And the point of those is to take your constellation of symptoms and allow me to put a number on it and to kind of get down on paper what it is that's bothering you. And my partners and I sort of use that form that you fill out as the starting point of our conversation to understand what is really bothering you. Because I can start launching into I could give this talk and the guy might say, well, you haven't even described why I'm here. So we do this AUA symptom score. The other reason we do it, well, two other reasons. One is the payers for these procedures, they want to know that the symptoms are bad enough to warrant the cost of this procedure. And then we want to know afterwards, did we make the fellow better? So you fill out these forms when you come in before your procedure, and then some months later we'll check it again, and we certainly hope that we've taken your symptom score and dramatically improved it.
Dr. Bennett,
Yeah.
could you address, since hormonal changes is huge to gerontology in general, so where's the testosterone effect in any of this?
It's all over. So the question is, where's the testosterone effect? So testosterone is made by the testes. That's how it got that name. And it's stimulated by the hypothalamus and the pituitary, sending signals down to the testes. Now, for men, testosterone production really ramps up around puberty, and it maintains relatively high throughout life, although testosterone production does taper off as we reach our 60s, 70s, 80s, and 90s. And there are other changes that affect how testosterone is metabolized and how it's bound and whether it's free and all of that. So, as we get older, we lose some muscle mass, and some of the other changes of testosterone deficiency might begin to appear. Not nearly as dramatic as it is for women going through menopause, but it does go down over time. Testosterone is the driver of prostate growth, and some are going to say, well, why don't you just use that as a treatment option? Give guys medication that knock testosterone down, and that would help treat BPH. Well, that would have so many other unwanted side effects, nobody would go for it. Now, we use those treatments for prostate cancer, and I sit down and talking to patients about, those medications when I'm going to give them, and I say, if you know anyone who ever went through menopause, talk to her, because you're going to experience those symptoms. But for BPH, the condition we're talking about today, it's not used. Okay. Now, if I were taking my boards, I'd have to say, well, finasteride, a medication I spoke about earlier, which shrinks the prostate, actually does interfere with testosterone utilization inside the prostate. So it's sort of tricking the prostate to pretend as if there's not enough testosterone around. Also grows hair. It's used Propecia. But even with that medication, sometimes guys come in and say, it's kind of helping my BPH, but my libido's down or my erections aren't the same. And so there's not a free lunch when you start messing around with testosterone. So this slide sort of depicts the way we approach patients. So when patients come in, often they just want to know what's going on. Why do I have these symptoms? Why am I getting up at night? Why do I have a slow stream? Why do I have urgency? And so after doing an examination and looking to see how well a fellow is emptying his bladder and talking about the options, many fellows will say, don't worry. Many fellows will say, okay, well, that's great. I don't think I want to take a pill every day, or I don't want to have a procedure. I just kind of wanted to know I'm okay. And so those are patients we call watchful waiting or expectant management. Typically, historically, if patients say, no, these symptoms are really beginning to erode my quality of life, or that of my partner, or they've gone into urinary retention and had to have a catheter or something, then we'll usually embark on the medications I spoke about earlier. Many of you have probably heard about Flomax, tamsulosin, or doxorubicin, Cardura, a whole bunch of medications called alpha blockers. Some of them help blood pressure. And those are sort of kind of the first go-to for urologists treating men with urinary symptoms. Some men don't tolerate them because they cause lightheadedness for some fellas. They can affect ejaculation, and a lot of fellas just don't respond to them, and they take the medication and they're not better enough. Or they're better initially, and then they come in 6 months later or 6 years later, and their symptoms have progressed. There are a suite of what are called here minimally invasive surgical techniques, MISTs. In that category, in kind of locally, if you wanted a MIST, you could get what's called Resume, which is the newest in kind of heating up the prostate. It uses a vapor. There's another technique called Urolift, which uses tacks to tack the bladder back, the prostate back. These, when we think about over my career, over about 30 years, 20 different things have come along, whether it's microwave or balloons that blast open. There's a thing we saw the other day that looks like a it's hard to describe. It's a piece of metal that you put in the prostate and it expands almost like a finger trap or a fish trap. It's hard. And it pushes on the prostate from the inside with these metal tines. That's there are countless. I mean, I'll go to this meeting at the end of April, the AUA, and there'll be booth after booth of new things that are going to fall into this minimally invasive surgical technique category. Suffice it to say that none of those technologies have really demonstrated equivalence with the gold standard, which is the transurethral resection of the prostate. So for 80 years, there's been this procedure called the TURP, and And many, many technologies have been developed to try to reproduce the effectiveness of that without some of the side effects and without some of the complications, without being technically so difficult to do for the surgeon. And we still, in our practice, will offer Resume and UroLift, although my partners who did the most of those techniques are less enthusiastic than they were 2 years ago. So if you're in the audience and you've seen Dr. Yu or Dr. Chan, and at one point they were really enthusiastic about these, and maybe they're less so now, they're less enthusiastic because they took care of a lot of patients who kind of got better, but didn't get better enough, or they got better initially and then their symptoms really came back. So the transurethral resection of the prostate, this 80-year-old procedure that has been updated, but has other problems, it still has remained really until aquablation is kind of the thing, the way we would treat this. And what this slide is really sort of getting at is that for patients who had really bothersome symptoms, if they were going to have a transurethral resection of the prostate, they had a very high likelihood of a good surgical outcome, but there were complications, and there was a trade-off, particularly around ejaculation. So in the classic procedure, going in and opening up the inside of the prostate, the ejaculatory complex is just taken out with everything else. Imagine, and I've used this metaphor, if you had a tangerine and you were going to go and take out all the pulp on the inside, leaving the peel behind, that's sort of what a TURP has been. And part of the tissue that you take out is responsible for ejaculation. So classically, after a TURP, a guy would come in and he'd say, hey, I've got a good strong stream, I empty my bladder completely, but when I reach climax, I don't have any ejaculation, which for some fellas is a real bummer. And that has been for many patients over the decades a reason that they wouldn't want to sign up for the transurethral resection of the prostate. And none of the other techniques that came along to try to preserve that element of sexual activity, they could do that, but they couldn't make the urinary symptoms improve like the TURP could. And that's where aquablation sort of came in. Let me see, do we have, and I'm going to go way back for a second to just tell you why that is. So, as I mentioned before, in a transurethral resection, just using this little cartoon here, the idea would be to take all the pink, what this look like sort of bubbles here. The prostate, when it grows into these kind of lobes and kind of a irregular tissue. And the idea would be to go in and shave all of that out right down to this black line here. But when you shave really close to the end of the prostate down here where the sphincter is, that's the ejaculatory complex. And it's hard doing a transurethral resection of the prostate to know where you need to stop. And the novel technology and insights of the people who developed aquablation was to say, hey, the business end of urination's up here. We can leave this alone. We can program the device using technology to program the water jet, and we can sync that up with real-time visualization by ultrasound of this area, and we can stop the thing from resecting that out in a way with a level of precision that you just can't do it when you're in the operating room shaving away. The landmarks are not as clear. And that's what gives this procedure its foothold. It'll take care of the difficulty voiding by taking away the vast majority of what's up here, but preserve most of the tissue down here and all of the tissue that is necessary for an ejaculation. I'd go just race back through these ones we've already gone over. So here's a comparison slide of aquablation versus TURP. Yeah, they talk about, I just go over the TURP, 100-year-old technique. When I do these procedures and have done them, it is astounding to me the bravery and courage of both the patient and the surgeon 100 years ago or 80 years ago when it really took off. No fiber optics, no halogen light, no widescreen TV. I do the procedures now with a screen that's about a quarter the size of this, but it's hugely magnified with fantastic anesthesia and all of this. That men would subject themselves to these operations 100 years ago or 80 years ago really is a testimony to how horrible the symptoms were, because these were complicated treatments with a lot of morbidity. Much of those severe life-threatening risks have been eliminated, of course, but it's still a technically challenging procedure to do. The irreversible complications refers to when you take the whole prostate out, or take the interior part, the BPH out, some parts of the prostate will grow back, but they won't grow back in a way that will restore ejaculation. When a fella comes in afterwards, historically, and he'd come in and he would say, hey, I pee well, but I don't have any ejaculation. Is that going to get better? My partners and I just say, hey, very unlikely. That is not something that's going to come back as the prostate kind of regrows or you heal. When we talk about a limited view of the prostate, we're on the inside of it. We're in this cleft and we're working out, sort of like a miner trying to open up a channel. With the aquablation, real time, there's an ultrasound in the bottom, which is giving a beautiful picture of beautiful to us, picture of the prostate, which really tells you like where you are and where this thing, how deep are you going, how far down the prostate have you gone, and so on. And when we're doing the transurethral resection of the prostate, it's me, it's my part, it's the surgeon doing it. There's no one else who is really saying, well, stop here, take more here, take less here. In the olden days, and like when I started, there was no camera, so you had your eyeball on this little lens, and it was sort of frightening because you're the only person who can see what's going on. Now it's on a big screen, and the technicians in the operating room and the anesthesiologist, everyone can watch. I don't think they do. I find it kind of boring for them. So I'm going to show you a little aquablation. I'll show you the procedure in a minute. But what's different? If here the 99% of men are reporting normal erections, normal arousal, does not affect your testosterone, does not affect the erections, and it preserves their ability to ejaculate, which is, I think, the second issue here. 89%. We have an early experience. I've done now 8 of these procedures. My partners have done another 10 or 15. So far, our patients are saying, hey, peeing well, and my ejaculation has been preserved. So will we have a perfect batting record, forever? Well, not likely, but 89% is a pretty good number to tell patients, hey, you can expect this outcome. Incontinence should be rare with this procedure, aquablation, and it's also rare with TURP because we are above the sphincter. We're not getting close to the sphincter like a radical prostatectomy would when you're taking the whole prostate out. Now, parenthetical, if a man comes to me and he says, I can't pee very well because of my prostate, but boy, I leak urine on the way to the bathroom. I cannot hold it. If we go back in the talk, that's due to the bladder. That's the bladder that's not relaxing. It's not the prostate. That's a bladder issue that's forcing that urine out. I tell those patients, hey, you're probably going to get better. 70% of guys who have this procedure have less urgent continence, but some guys still have that. And I think I've got 1 or 2 fellows kind of in the on deck circle now for a procedure. We're going to take care of their prostate, and if they still leak, then I'm going to take care of their bladder, often with Botox. We can put Botox in the bladder and kind of calm that muscle contractility down. So 99% of the patients don't have incontinence because the sphincter is well preserved with this. And then the last number here, 94%, that's an important number. That's referring to who needed another procedure done. And if we look at those other missed procedures, UroLift, Resume, certain forms of laser stuff, this new kind of paper clip going into the prostate, the weak link has been that those procedures have had to be repeated. That patients say, well, that was better for a while, but not so long and not so good now, and I think I got to have it done again. And that's kind of a bummer. Our goal is to do a procedure and have that procedure durable through the remainder of the fellow's life. So this just goes over some of the features of aquablation. I mentioned about the ultrasound, and we'll take a look at that in a second. Personalized treatment planning, meaning that when Molly is there, or her colleague yesterday, Peter, they are experts at the computer, and I'm an expert at the prostate. And we use a lot of ultrasound in our practice for prostate biopsies and so on. So we set everything up, and then I use Molly and her colleagues to determine exactly where this template is going to be formed so that we are resecting just the amount of prostate that I think is going to have the biggest impact on the patient. And so every prostate is different. Every template is personalized to that individual. The robotic assisted execution, one of the things, AI has made it into the operating room, and in medicine in a lot of ways, but in the operating room, Marin Health went out and bought the best, newest version of this platform, and it's really remarkable. I set up the treatment plan yesterday with fellow Peter, and then there's a button you push that says, AI assist, and it's sort of like having someone correct your homework. It says, okay, that's what you think would be best. We think it might be a little better if you just adjust the template. And yesterday, in fact, we went back with what we wanted because I'd already looked in and I had some thoughts about the fellow's anatomy. But it is using 50,000, 60,000 prior procedures to say, this is sort of the template that seems to be best fit based on this guy's anatomy. So, like all AI, it will become even more powerful over time as more and more cases are done. Heat-free water resection. In other words, the TURP, the one I've been talking about earlier, that uses an electrical current through a wire to shave the prostate out. For my entire career, folks have said Roto-Rooter. It is not Roto-Rooter. We don't get paid as well, number one. And secondly, it's always been a precise procedure, under direct visualization, using a wire to carve away things and then cauterize. It's not like a drill bit or something like that. But in this procedure, it uses a water jet, much like your power washer or the kind of water jets they use now to cut steel. And that removes the prostate without heat. Now, we do use the standard resection, the TURP electrical wire with the current and whatnot, after the water jet to go in and cauterize any vessels that haven't stopped bleeding. But the principal technology is using this water jet to remove the bulk of the tissue. Okay, so here is this must be version 1.0, Molly? Okay, yeah, a question. Oh, great question. So when we're doing a TURP, and I'm in there and I'm using this electrical wire to kind of cut tissue out, it's floating back into the bladder. And at the end of the procedure, I use a very cool little device to kind of wash it all out, and we send it off to pathology. In this procedure, the ablated tissue is also going into the bladder, but it is aspirated out by the instrument because it's putting water in and it's taking it out at the same rate. And in fact, it's very well regulated to make sure that it puts it in and takes out the same rate so you don't fill up the bladder. At the end of it, though, there is tissue that we send off to the pathologist. And so there is a specimen, although it probably is not, it's not the volume of tissue that we would send to the pathologist after a TURP, but the tissue does come out, it's sort of morcellated. I would say that, another sidebar here, if we think a fellow may have prostate cancer due to his PSA or his physical exam, family history, we work that up before we go in and do these procedures because these are not cancer procedures. And if it would be a bummer if I did this procedure on a fellow and 3 months later I found out, well, gee whiz, you actually had prostate cancer we didn't diagnose. So that little sidebar there about the tissue that we are removing here is not as critical as if we're doing a cancer operation. We really need to see that tissue at the pathology department. So I think if I push a button here, this is going to do a little video of what's going on. Let me kind of orient you here. This is an image taken by an ultrasound probe, which is in the bottom, which is down here. So the patient is lying flat, his legs are up, much what we call lithotomy. It's sort of the position you'd be in if this fellow were having a baby, which would be very complicated. But the probe is down here, and then it's showing me the prostate. Now the bladder is over here. The urethra and the sphincter mechanism is here, and the urethra is coming out here. These bright lines here, this is the scope, the cystoscope that I'm using going into the urethra, and the end of it is in the bladder. So there's a probe in the bottom. This fellow's asleep, fast asleep, which is important for his comfort, but also because I can't have him move during this procedure. Everything is set up, and movement is not okay. So we always talk to the anesthesiologist as we're just about to go. We've got everything set up, and we say, okay, no movement now, and they usually kind of give a slug of propofol or something to make sure that there's no movement. So orientation, this is the prostate, the bladder's over here, the penis is down here. These ultrasound signals, this is the part of the telescope where the lens is, and these are elements of the Aquablation jet. Yeah.
You're able to see this by an instrument that's inserted up through the urethra?
Exactly. Yeah. So we go in, the probe goes in the bottom, and I got this great view. Then I take the telescope and I go through the penis into the bladder, and then I line them up and I fix them to the table via these I think there was actually a picture of.
Is there bleeding during this procedure?
I'll get to that. Yeah. Good question. So if I hit the button here, oh, by the way, I was referring earlier to the area that gets spared that allows men to preserve their ejaculation. This is the zone, and as the Aquablation device goes along, you think of it like a windshield wiper under very, very high pressure water jet, and it's going and it's removing tissue, and when it gets to that yellow area, it creates a whole new template, leaving the area where the ejaculatory complex is, and then kind of taking the prostate out, above that area on each side in a way that you just couldn't do it freehand in a transurethral resection. So here, let's see what happens. This looks like what's going on when we're setting up the different points of the resection. So the cursor there is the surgeon and the technologist going around and saying, well, here's how we're going to do the template. And then, this, by the way, is version 1.0. We're using one that's with somewhat different, a little bit better visualization. Now, let's see. It looked like, is that the end of that video? Okay. Okay, so here's an illustration. So I'll show you this one. Here's the scope. The lens is here. Going out to the tip out there is going to be where the water jet is in the aspiration. Here's what I'm seeing during the procedure. I'm watching it on a big version of this ultrasound. And then here's the exciting part. Here's the car chase. So you can see that water jet is just blasting the tissue away as it goes, and then it gets adjusted to follow the contour of the prostate that we've determined ahead of time.
The objective is to just lower the size of the prostate?
It's to remove those pillows of tissue that are blocking the flow. And you can actually, it's kind of cool, you can see it in the ultrasound view. You can just see that all of a sudden there's this big channel that has developed. And down in that little screen, you can see the jet there blasting away. What it does down here, this is where it's adjusting the template to preserve ejaculation at the very tip. Now, resecting that much tissue, let's just take an average prostate, would take 45 minutes. A cycle of that, which you just saw, takes about 3 minutes and 10 seconds. It just goes zhink. Now, the company realized over the first several thousand of these that we got a better result, they got a better result if we went back and did a second pass. So we go back to the beginning, we look at the ultrasound, we adjust where the prostate edges are because we've just made it smaller on the inside so it contracts a little bit. We reset up a template and press go again, and it goes over it. If you ever mow a lawn, you sometimes think, it looks okay if I go over it once if it's really long, but if I go over it twice, I get a much cleaner look to the lawn, and that's sort of how this works. Yeah.
How much do you take out? You just take not the whole, just a little bit.
Yeah, that's a great question. There's a view that we have when we're setting up the plan that is not in here, and that's the view of a cross-section of the prostate. And the device allows you to pick how big a piece of pie you want to take out. So the probe is on the top, and then the pie, the edges of that pie piece come down. And with the technologist, we move the cursors around to determine the sweep of that water jet. We don't want to get outside the prostate, the capsule. That would be a problem if we put a hole in the whole prostate. And there are parts of the peripheral zone that we'll leave intact as a sort of a safety measure of not ablating too much. But we're probably taking out sort of 50 to 60%, which historically that's sort of what you would do with a transurethral resection. Yeah, again, I always think of it as two gigantic pillows, and they've come in and they're rubbery and they're blocking the flow, and I'm just taking it back as far as I safely can, and that's what this is doing. Mm-hmm. What about the channel is much bigger. Channel is much bigger. Now the whole prostate contracts a little bit because you've taken out the inside, you've kind of taken the stuffing out of it, so it contracts a little bit, but it still leaves a nice big channel, which when patients come back to the office, I put that ultrasound that I used before the surgery to show them their prostate, put it on there again, and there's this big channel that we've created. Okay. Let me just see what the next slide is. Okay, so there was a question earlier about bleeding, and when this technology came out, there was a thought that, hey, maybe this water jet would somehow impact the blood vessels so that they wouldn't bleed, or if they did bleed, we could put a catheter in afterwards and put some compression using a balloon, put some compression on the prostate, and that would stop the bleeding. And that was the initial experience, but bleeding was a problem with the procedure. With a TURP, we use a lot of this electrical current through that wire to cauterize vessels all along. I was on the sidelines watching this. I went down to Stanford and watched a great surgeon down there do a number of them, and he was of the early group that said, hey, you know what? There's not much bleeding with this procedure, but there can be some. And so after we do the aquablation, we're going to go in and we're going to cauterize areas. We're going to clean up any areas that didn't get taken out that we think ought to be removed if the computer didn't quite get every single part out, but we're also going to cauterize vessels that otherwise could bleed. And I was telling Molly when she got here, I did 2 cases yesterday, and my partners and I have modified how we do that post-aquablation sort of cleaning up, which is something we are so familiar with from a career of doing standard resections. And my patients both went home yesterday with clear urine and catheter. They go home with a catheter over the weekend, but no bleeding at all, really no significant bleeding at all, which absent that attention of a surgeon could be a major problem. So it still involves a lot of sort of technical know-how, but the bleeding, we believe, appears to be quite a bit less than it can be under the standard procedures.
Just make sure you take out about 60% of the prostate.
I think so. We don't typically go back and quantitatively measure, but classically, that's sort of what one would expect to remove. Okay. And the prostate, has a sphincter mechanism in it, and I mean, there's a lot of stuff. The radical prostatectomy does a great job of taking the whole prostate out. Well, then guys have erectile dysfunction and they leak urine, and we're not, so we're not trying to take the whole thing out. Yeah. So this is just sort of what we would tell patients ahead of time, that during the procedure, we put a catheter in to irrigate any blood that is oozing out of the area where it was resected. Typically, patients will go home with that catheter for a few days. In our early experience, we admitted virtually all the patients. Yesterday, my patients did so well with this kind of modification that I was doing that I sent them home. Both preferred to go home. Our goal over the next year or so is to develop a protocol and a technique that most patients can go home. Some patients actually prefer to be in the hospital overnight. They've got a catheter in that's new for them. They're getting over anesthesia. Our practice is accommodating to what the patient and the family prefer. And then, much like the standard resection, it's going to be a few weeks before that lining regrows in that larger cavity. And so I tell patients, you can walk every day, but I wouldn't do any vigorous exercise for about 3 or 4 weeks, just to allow that area to heal, because there will be some intermittent bleeding, in a kind of a annoying but not significant way during that time. Two questions. Let me just take one here.
Use a microphone so that everybody can hear the
sure.
question, if that's all right. Thank you.
I have a question. I had laser surgery last year in March, and it was very successful for a 6-month period of time, then gradually began to break down a little bit to where some of the symptoms have reappeared. And I'm wondering if something like this would be practical to go in and try again.
Yeah. So laser surgery, the question is, your point is that you had a procedure, then the symptoms came back. And this is what I was getting at with many of these other procedures. The laser is interesting. When I first did a laser procedure, Greenlight was the brand. My senior partner and I, we did that, and we just thought, wow, TURP is over. The standard procedure that we learned, it's over. The laser is so cool. What it does is it vaporizes tissue, and it basically uses heat, and it just boils tissue away. Sounds kind of great from the surgeon standpoint because it doesn't bleed. The problem is you've got this big, remember that diagram with all that rubbery tissue? Well, it does a really good job superficially. It does not do a very good job as you get deeper, because you have already boiled all of the water out of the tissue. Imagine if you took a blowtorch to a tree. You'd be on the bark and you think, this is awesome. I'm just blowtorching this tree away. Well, about 2 minutes later, you'd have charcoal and nothing would be happening any longer. And so what your experiences with the laser was the reason my partners and I did it for about 6 months. We saw a bunch of patients back. This is now 15 years ago. And they had a lot of prostate left. And we just said, we're going back to what we know how to do, where we precisely remove the tissue. We're not vaporizing it. Now, I have patients who had lasers done by other practices, and they're still happy. And if that's the case, super duper. But way too many men have had the problem exactly as you've described, that the symptoms came back because not enough tissue was removed. And that's why we waited on the sidelines until this came along, because this procedure is just a faster, in some ways more precise version of the procedures we've already been doing that remove the tissue. So it's almost as if, you've been using, a tool in your shop for, 30 years, and somebody came along and said, hey, this one's cordless and it's got a better bit on it. And by the way, it'll make that cut kind of precise every single time, So anyway, there's a question here.
Two-part question. Catheter, what is the range of days that you may have to have a catheter? And the second is, what are the risks of infection?
How long will you have a catheter after this procedure? In our practice, we would say, I don't know, these guys are coming back on Tuesday, because I'm in Nevada on Monday, I'm down in Greenbrae on Tuesday, they're going to come in on Tuesday for their catheters to be removed. I had, in my early experience, I had a few guys who bled more, so one got a catheter in for a week while we were waiting for the bleeding to go down. But we're aiming for 3 to 4 days. That's typical. And infection is something that we check for ahead of time. We treat it while the catheter's in, and we treat it when the catheter comes out. So the infection rate should be low if we've done our homework.
Any other questions? Do you mind can you take a few
Yeah.
Thank you. There you go.
Thank you very much. I had a procedure roughly a year ago. I think it was less invasive. It involved mesh. Does that ring a bell?
Who did the procedure?
I'm having little memory issues these
Okay.
days. I think his name was Grant, possibly.
Was it in Marin County?
Yeah.
I don't mesh, and we use mesh, but that's usually for hernias and things of that nature. There's not an application that I can think of for mesh. Now, they might have been talking about MIST, this minimally invasive surgical technique.
Yeah, actually, it was a hernia procedure, so I think I've gotten myself muddled here.
Okay, well, if it was, if I did it, I hope it didn't come back.
Yeah, so.
A question in the back?
Regarding the sexual dysfunction side effect, is there any procedures that can restore that?
Yeah, so I think about sexual function in sort of this whole, there's a whole bunch of issues. There's libido, and there is, fertility, and there is ability to get an adequate erection, and then to reach climax, and then the ejaculation. Yeah. If you've had a procedure, this or others, that have made it that you do not any longer have ejaculation, I think it's most accurate and fair to say, no, there aren't procedures that will restore that. And I have had patients say, well, 4 years later, it started happening again or something. And I know guys can be disappointed around this. I just say, well, sometimes the conversations get sort of awkward. I say, well, look, is your partner bothered by this too, or just you? And I try to get guys, when I was just doing the TERP, I would have people reconcile that before they signed the consent form. I'd say, this doesn't seem like a big deal to you now, but imagine having ejaculation, reaching orgasm and not having an ejaculation. Just get your head around that, because that's going to be your reality. And most guys are like, okay, well, I can do that. But now they have an option. Question in the pink shirt here.
There's a procedure that's being done at UCSF, I think, that uses high-frequency sound to remove the tissue of the...
Okay, great. HIFU, high-intensity focused ultrasound.
Right.
High-intensity focused ultrasound is really a cancer procedure.
Okay.
So it has a lot of similarities, because they're using technology to guide. They're using imagery. Usually it's MRI at that time. Sometimes ultrasound, sometimes MRI. But that's a cancer procedure.
Okay.
There are other procedures for an enlarged prostate. I thought you might have been saying that there's one called HOLEP, using a laser to take out a very large prostate. A prostate may be too large for these other technologies. But high-intensity focused ultrasound is for cancer.
And there was a procedure that was an outpatient procedure that they used the high-frequency sound from outside the body on the prostate.
I'm not familiar with that. I am not familiar with any treatment for benign prostate hyperplasia that uses high-frequency ultrasound.
Okay.
Whereas I do send patients to UCSF and Stanford for cancer.
Okay.
Yes,
thank you.
in the brown, with a brown sweatshirt, maybe back here. Yeah.
Hang on. Excuse me. This is awkward.
Having this procedure, can it help with kidney function also?
Great question. Will it help kidney function? A complication of not emptying your bladder that I did not go into, but it was alluded to on one of the slides. If a fella is not emptying his bladder due to BPH to the point that he has a residual of, let's say, half a liter or more, that pressure may be backing up to the kidneys. And I have a couple guys kind of in the pipeline right now who were identified as having renal insufficiency. They went to a nephrologist. They had an ultrasound, and it showed a huge bladder. Usually these guys are not aware that they have urinary symptoms. For those patients, aquablation or any procedure that allows them to empty their bladder more completely will likely improve kidney function. It doesn't make the kidneys grow back, but it stops the high pressure stress on the kidneys that has caused the problem. So yes, but with caveats. That's something that your urologist and nephrologist and internist will be able to counsel you on ahead of time.
How
yes,
long-
ma'am, yes.
You mentioned how many procedures your practice has done.
Yeah.
But how long has this been around and how many total?
I think it's 100,000 now. Molly, when was it first done and how many cases?
Yes, so the technology was created in 2017, and we got Medicare coverage in 2020, so that's when things really took off after we got Medicare coverage. The technology that Marin Health has, the second generation of this system, has combined information and data from 70,000 procedures to help with create the AI. So there's been over 100,000 procedures done.
So, and for our group, we're super enthusiastic about it. And there's just it's just like anything else we've adopted. There's a sort of a learning curve to say, well, how do we feel? I was speaking to Molly about this meeting. The international meeting occurs in 6 weeks or so. And I'm going to spend a lot of time talking to people who've done 500, people who've done a lot. They've seen every permutation. Who are the best patients? Who are the patients that might be more challenging? What tricks of the trade seem to work best?
Is this on?
Oh, there's a question back here.
This is on, right? Okay. So you may have addressed this already, but I was just wondering, is there a possibility of reoccurrence? Because what I heard before was that parts of this growth, in the inner, was due to testosterone. So is there a possibility for that to come back again?
That's a really, really good question. And with any of these procedures, with the TURP and with the aquablation, the tissue can continue to grow. Fortunately, in the vast majority of cases, it doesn't grow enough during that fellow's lifetime to become an issue. And even when we do see sometimes like I'll come in with a stone or bleeding or something, and I'll look in, I'll say, oh, after I did a resection, 2 years earlier, oh, there's some tissue that's come back. Usually it doesn't cause the type of blockage that they came in for originally.
Great. Well, given this, let's go ahead and give.
One more, please.
Okay, here's our last question for today.
PSA test. Could you comment on those? Because there's a lot of controversy.
Okay, I'm going to give you
Doctor says your PSA is high.
okay, I'm going to give you an elevator speech from like the 3rd floor down to the lobby. PSA, the prostate-specific antigen test for prostate cancer, very controversial because it led in the early years to overdiagnosis of insignificant cancer, and many men underwent biopsies they probably could have been spared. For a man who has a likelihood of living 10 more years, there seems to be an advantage to getting screened annually. And we call this shared decision-making. So whether it's with your urologist or your family practitioner, your cardiologist or your internist, if you are under the age of 69 or 70, probably benefit from having your PSA checked every year. If you're 69, 70 or older, shared decision-making, talk to your doctor about the pros and cons, because in my early career, when everybody got tested and everyone got radiation or surgery for prostate cancer, many, many men were overtreated. So it's a great short question, long answer.
Thank you so much. Let's give Dr. Bennett a round of applause.
Thank you. Thank you.